Care of the Aging Adult, Assessment Unit 3. This is Martha Olson from Iowa Lakes Community College. In this, we will be looking at the physiological systems and how they interact or impact other physical systems as the person ages. Our comprehensive assessment will be looking at all of these different areas because we know that they work together, and you will be completing all of these areas as you get to clinical at the long-term care facility working with the older adults. Standardized tools are typically used as we do an assessment, such as a Braden scale, their risk for skin breakdown. But what we also need to consider is some of their sensory deficits. Can they hear when we ask them questions to complete these standardized tools? Are they able to understand what we're asking? When we think about how we assess older adults, I often think of the story with a doctor I made rounds with his older adult patient. He always would go in and ask what day it was, what time it was, where they were at, and who they were. And as soon as he left the room, this older lady looked at me very seriously and said, "I'm not sure I want him to be my doctor. He doesn't even know what day it is." Could he have asked in a different way to kind of complete that assessment for her cognitive status? Perhaps so. When we think about the cardiovascular system and all the changes, it's very important that we understand how that will impact all of the other systems. The arteries dilate and stiffen. That oftentimes causes hypertension. The peripheral arteries stiffen due to the accumulation of calcium, lipid, collagen residues. Sometimes older adults have a loss of pacemaker cells. That prolonged contraction and relaxation phase with age will correlate with extended release of calcium. Increase in arterial stiffness, that resistance increases with age in that aorta, the arterial walls, the periphery. And when we look at that, we know that our older adult is at higher risk for like an abdominal aortic aneurysm. The blood vessel viscosity increases, meaning that blood oftentimes gets thicker and it has to run through these very stiff veins and arteries, causing a lot of problems for that person with the inability to vasodilate and constrict to change their blood pressure as needed. Cardiovascular response is very different from the response of younger individuals. We've talked before about older adults oftentimes have very different symptoms that they present with when they have an infectious process and a cardiovascular event as well. Sometimes they will stay home thinking they have the flu when in fact they're having an MI. They feel lethargic, they feel a little feverish, they just don't feel like themselves, and it's not that massive crushing chest pain that a younger person might feel when they're having an MI. So the cardiovascular changes are very important. As we look at some of the other changes, we know on assessment we will be noticing perhaps clubbing of the fingers with long term. Remember, the clubbing is from long-term oxygen deprivation or maybe a COPD emphysema. That bruit is that hearing of the blood through the vessel. Usually we listen to a carotid artery with our stethoscope and can hear that bruit. And then the left versus right-sided heart failure is important to think about as well. Left side, remember, backs up to the lungs and you hear the rales and rhonchi, the adventitious lung sounds, and the right-sided heart failure backs that fluid up into the body. Jugular vein distension, edema, fluid overload showing up more in the body systems. As we look at edema and what happens in the older person with edema, we go back to that one liver enzyme or that liver protein called albumin, and we know albumin helps control osmotic pressure. The normal albumin level is 3.5 to 5.1. As we look at edema, we can see then that it's from that increased hydrostatic pressure, that oncotic pressure that would be improved if they had more albumin. Perhaps it's a lack from the diet, or they have liver failure and the liver is just not making what we need. And that obstruction then can lead to some edema, especially to the lower extremities in that older adult. When we look at our nursing interventions related to edema, we think of getting that admission weight. It's a nursing intervention. We do not need an order to do that. And then get that weight every day. on the same scale at the same time of day so that it's consistently recorded and obtained. An increase in weight gain needs to be reported because maybe they're having fluid retention, and that's an early indicator for that. And maybe they need a little more diuretic, maybe they need a little more fluid restriction, or something else that can be done. On admission, make sure that we're putting the bed and everything on the bed that the patient will be weighed with the next day. So when we zero the bed, where I work, these are the rules. The side rails are up, the head of the bed's up 30 degrees. You make sure that if they're going to have telemetry, you put that on the bed as well. So when we weigh them the next day, all of the things that we weigh with the patient will have been accounted for when we zero out that bed. When we look at the respiratory system, we know that that loss of elastic recoil causes the lungs to permanently have changes. It traps air inside and it prevents the lungs from emptying completely. That reduced ability of the lungs then to expand during inhalation, less air reaches the lower lobes, and they oftentimes will then kind of have like a dead space down there, causing them to have lower O2 sats, lower oxygen that is exchanged with carbon dioxide to keep them well oxygenated. That chest wall gets stiffer. It makes it harder for that thoracic cavity to expand. They have to work harder to breathe or to get a breath because of that chest wall stiffness. We notice changes such as kyphosis, lordosis, scoliosis. Kyphosis is the most common with your older adult. That's the little hunchback that they have, and when we think of the impact on the rib cage and on the ability to take good breaths, that can very much be a detriment for good oxygenation in the older adult. Arthritis in the costovertebral joints, increased rigidity in that thoracic cavity, the diaphragm can become weaker, and as a result, that vital capacity of air in and out can reduce by 40 to 75% by the time that person gets to be 70 or 80 years of age. And we think of COPD and pneumonia. We also know that besides the loss of elastic recoil in the lungs, we also see that barrel-shaped chest with many of our patients that have respiratory changes due to aging or disease process. As we apply oxygen, we know that we need that physician's order, but we assess early by getting an O2 sat. Apply oxygen at 2 liters per nasal cannula if that's appropriate, and then continue to assess and evaluate if it's improving. Is it ongoing? Make sure we document it, get the physician's order to let him know that we needed oxygen, and don't be afraid to use that respiratory therapist that might be working to have them come in and help you assess and help you evaluate the need or the use of oxygen for them. Don't get the oxygen up too high if it's a patient that has COPD, emphysema, any of those chronic conditions, because as you remember from intro, that decreases their stimuli to breathe, and we don't want to knock out their stimulus to breathe. When we look at the GI system, I think of the 9 Ds of geriatric weight loss that are often talked about. Dysfunction, disease, depression, diarrhea, dentition or lack of teeth or dentures, dysgeusia or lack of taste, dysphagia, problem swallowing, drugs, including their medications, and dementia. So oftentimes the 9 Ds of geriatric weight loss, when we look at those, we think of what really is the underlying cause of their loss of weight or the cachexia that they are experiencing. There's generally relatively few changes to the GI system. There's really no changes to the secretions of the pancreas and the gallbladder for the older adult. They are at higher risk for things such as gallstones and constipation, fecal incontinence, and infections with aging. But otherwise, the GI system tends to work fairly well for the older adult. The GU system, we know that there is a decline in the glomerular filtration rate, the elimination of wastes and toxins decline, and that can lead to a harmful accumulation of things such as uric acid and medications. When you have a patient on a digoxin, on a cardiac glycoside, some of the early signs that they are toxic from that are seeing halos, vision changes, and sometimes nausea and vomiting. And that can be related then, that interrelationship with the kidneys, because it is not eliminating the dose of digoxin they took yesterday and the day before. So as we look at the older adult, we also want to remember that incontinency is not a normal finding in the elderly or a normal part of aging. It seems like we think that because if you work in long-term care, you might have older adults that you care for that have urinary incontinence, but it is not considered a normal part of aging. When we look at the bladder and the urethra, we know that the amount of urine expelled from the body can decrease with age, and that kind of correlates with increases in post-void residuals. We know renal changes affect the ability to concentrate and dilate or dilute urine, and that in itself can cause electrolyte imbalances. Increased water loss, sometimes with aging. The voiding at night is called nocturia, and often your older adults will not drink anything after 6 or 7 p.m. because they don't want to have to get up and go to the bathroom at night. Urinary retention, difficulty voiding, UTIs, renal failure are things that we think of with this system as a person gets older. For the males, we want to look at the prostate. Is that prostate causing maybe some urinary retention, dribbling, difficulty voiding? And for the female, maybe that lack of estrogen can be causing some of those changes. Our total body water then varies with the amount of body fat and the age that a person is. Fat is water repelling or hydrophobic, and so if you put oil on your hands and try to wash them, you notice that you get beads of water on your hands, or after you wax your car, you notice beads of water after it rains. That's kind of what happens in the body as well. The metabolism of medication then is different because of total body water, and many times you will see the elderly start on a medication at a lower, sometimes even half of the usual dose for an adult, simply because of the changes to the kidneys and toxicity, and then that total body water that changes or diminishes with time. How do we assess hydration on the older adult? Remember, skin turgor is not the most effective way to tell about the hydration status because of the changes to the skin. Look at their mucous membranes. Look at the skin turgor. If you do that on an adult, older adults, they say use the forehead, not the hand. Look at the urine color. Don't measure intake and output because that is very inaccurate. We're very not always so good at getting the INO being exact, and then you think about insensible loss, like loss of urine or loss of fluid, body fluid through feces, sweat, and our breath. And so we do not want to do intake and output as an accurate way. Sometimes the blood pressure is a much better way of telling the hydration status of a person, simply because it can tell us what's going on inside the vessels. Hypertension tends to go with volume overload, and a person with fluid volume deficit might have a real low or hypotensive blood pressure. And when we look at hydration and think, what is the big deal? A person that's overhydrated might have congestive heart failure or kidney failure. They're not able to pump or eliminate the fluid that they have. Our assessment is going to be looking for that jugular vein distension. Remember, 30 degrees, turn the chin to the side and look at that neck vein. Take their blood pressure. Check the edema to the extremities. Confusion can also be a sign of overhydration because it causes electrolyte, sodium changes. And then listen to the lungs. And these really aren't in order of what I would do, because if I was following Maslow, I would probably put on here, listen to the lung sounds first, then probably look at my jugular vein distension, move down to the blood pressure cuff and getting the blood pressure, and then moving lastly down to look at the edema. For dehydration, we want to think about, are they on too many diuretics? Or are they just not drinking because they have dementia or loss of that thirst sensation? And our assessment is very much different than what we just talked about. They're going to have very dark concentrated urine with high specific gravity, dry mucous membranes, and possibly hypotension, but their heart rate is going to be moving faster or tachycardic to compensate for that. Your pulse might be a little thready as well. This ends the first part of what we're doing, and I will pick it up in the next one. Thanks.